Hey, this is Yes Prakash. The primary objective of this lecture is to define syncope, provide a physiological framework for classifying it, list some causes of syncope, outline the pathogenesis of neurally mediated syncope, which is an extremely common cause of recurrent syncope, and then outline the clinical approach to evaluating the patient with recurrent unexplained syncope, outline the approach to distinguishing syncope from an epileptic seizure, discuss briefly the pathogenesis of neurally mediated syncope, and so that's the objective of this lecture. It's at best introductory, but with a focus on physiologic mechanisms, particularly of neurally mediated syncope. All right, so syncope is transient loss of consciousness, and it's no more than 30 seconds, 5 to 30 seconds. It's that transient, and it's associated with the loss of postural tone. And this is because the underlying problem is a transient global cerebral hypoperfusion. And it's followed by full and spontaneous recovery without residual neurologic deficit. The global cerebral hypoperfusion means that you have a reduction in flow to all parts of the brain, including the brainstem, which is why there is loss of the postural tone, and then there is loss of consciousness as well because of brainstem hypoperfusion. And there is spontaneous recovery. So note the definition of transient. The loss of consciousness is usually no more than half a minute. So the spell is pretty brief. The cumulative incidence is about 40% by age 60, and it constitutes the basis for a good proportion of emergency department visits. Depending on the case series you read, it will be anywhere between 1 to 2% and 3 to 5%. That's in emergency departments alone. The framework is, well, I'm a physiologist, so my framework is going to be that of physiology, and that's what I recommend that you do when approaching a patient with syncope. So cerebral blood flow is mean arterial pressure divided by cerebral vascular resistance, right? And so cerebral blood flow is equal to MAP divided by cerebral vascular resistance, and that's cardiac output times systemic vascular resistance divided by cerebral vascular resistance. So a reduction in cerebral blood flow has got to be either due to hypotension or due to an increase in cerebral vascular resistance. Invariably, it's due to hypotension, but then when it's due to hypotension, it could be because of a drop in cardiac output or systemic vascular resistance, or both. And rarely it can be because of an increase in cerebral vascular resistance. That entity is called cerebral syncope. So this is the physiological framework, and using this, we can actually classify syncope based on the hemodynamic abnormality leading to hypotension and the essential features, including the cause of the hemodynamic abnormality. So first, let's take a drop in mean arterial pressure, due to a disease process of the heart, which leads to an abrupt reduction in cardiac output. It could occur, well, it typically occurs with exertion, but it doesn't have to. It may be triggered by emotion in some instances. Examples of cardiac causes of syncope include instances where there is left ventricular outflow obstruction, like aortic stenosis, hypertrophic cardiomyopathy, where a reduction in stroke volume during exertion could underlie the fall in cardiac output, therefore the drop in mean arterial pressure. Or it could be an arrhythmia, which occurs in the wake of exercise, or it could be emotion or something else, like arrhythmogenic right ventricular cardiomyopathy, or it could be a advanced bradyarrhythmia, like advanced second-degree AV block or third-degree AV block, where the heart rate is so low that the cardiac output falls and it leads to hypotension. It could be a tachyarrhythmia, like in long QT syndrome complicated by polymorphic ventricular tachycardia or catecholinergic polymorphic tachycardia. So these are all instances in which you have a cardiac basis for the fall in mean arterial pressure, and the fall in mean arterial pressure is primarily due to a drop in cardiac output. Okay. All right. Now, if we go to the next category, we have a fall in mean arterial pressure that is primarily due to an impaired increase in systemic vascular resistance within 3 minutes of standing. So, you know, upon assuming the upright posture following a period of recumbency, adaptive mechanisms are activated that enable blood pressure to be maintained without falling, right? So orthostatic hypotension reflects the failure of that, and with the fall in systolic more than 20 millimeters mercury and diastolic more than 10 millimeters mercury at about 2 to 3 minutes of quiet standing. It could be, it's very commonly due to ECF volume contraction due to any cause. It could be due to the individual taking vasodilator medications like alpha blockers for some other purpose, like, you know, hypertension or prostate hypertrophy. It could be because of ECF volume contraction due to deficiency of adrenocortical hormones, the mineralocorticoids and glucocorticoids. Or it could be because of a problem within the autonomic nervous system that, you know, results in, for example, a deficiency of norepinephrine release by sympathetic postganglionic neurons. Now so that's classic orthostatic hypotension. And here in orthostatic hypotension, the patient's concern is going to be one of orthostatic intolerance, you know, feeling lightheaded upon standing. And usually they're not able to, you know, assume the upright posture without getting lightheaded. And then they, you know, sit down or have to lie down to relieve the symptom. So that is orthostatic intolerance, and orthostatic hypotension is an objective sign of it, and whereas orthostatic intolerance is a symptom. All right, the next category is when you have a fall in mean arterial pressure due to a decrease in systemic vascular resistance and or cardiac output QS. And that is solely due to abrupt withdrawal of sympathetic nerve traffic to the heart and blood vessels and an increase in cardiac vagal outflow. So an increase in cardiac vagal outflow would lead to a fall in cardiac output, whereas if you abruptly withdrew sympathetic nerve traffic to the blood vessels, that would lead to abrupt vasodilation. So abrupt vasodilation occurring with or without bradycardia and or asystole underlie the hypotension in what's called neurogenic syncope. It's a reflex problem. It's called neurally mediated syncope or reflex syncope. There are so many synonyms. A very common terminology is vagal syncope. Vaso referring to the fact that there is abrupt vasodilation, and vagal referring to concomitant activation of vagal outflow to the heart. A very common trigger is, strong emotional faint. In some instances, it could be protracted coughing. For some, it's provoked by, the act of micturition. And then there is a related entity called the carotid sinus hypersensitivity syndrome. I'll get to that later in the presentation. And finally, as I mentioned earlier, you can have, in the absence of hypotension, syncope due to an increase in cerebral vascular resistance. This is an entity that's called cerebral syncope. And the way to document it is in an individual with syncopal spell, you can examine them and if they happen to have an attack and you measure, the cerebral blood flow velocity during a syncopal spell, using transcranial Doppler, and you find that their mean arterial pressure is normal during the spell, but their cerebral blood flow velocity is decreased. And so that is evidence of cerebral vasoconstriction as the basis for the reduction in cerebral blood flow. That's how that's diagnosed. Now, how do you evaluate a patient with unexplained syncope? And first, a meticulous history is very important. The first question is this a patient with syncope, or is this something else? Is it something like a fall, or is it a transient ischemic attack, or is it an epileptic seizure? That is an important question. What are the associated symptoms? Does the patient have, for example, exertional angina, exertional dyspnea? Is the patient otherwise predisposed to heart disease? So a meticulous history is very important. What is a typical syncopal spell like? What are the provocative factors? Is it brought on only by exertion, prolonged standing, motionless, or emotion or exercise, or does it happen, at rest with the individual seated or even supine? And then, distinguishing syncope from epilepsy is an important thing, and I have some notes on that specific issue on the next slide. Likewise, when we do a physical examination, we're going to have to look for evidence of heart disease. Say if there is a murmur, like would be expected in a patient with hemodynamically significant aortic stenosis, or a patient with hypertrophic obstructive cardiomyopathy. Is there a murmur? And then you can check for orthostatic hypotension in individuals with recurrent syncope, because orthostatic hypotension is going to predispose to syncope. Then a baseline ECG, where you assess for, say, prolongation of QT interval, that may be apparent. The focus of the evaluation, and this is the key thing, is in any patient with unexplained syncope, the focus of evaluation is first assessing whether this patient has structural disease of the heart, like aortic stenosis or hypertrophic cardiomyopathy, or a functional disease process like a channelopathy, like arrhythmogenic right ventricular cardiomyopathy, long QT syndrome, or catecholinergic polymorphic ventricular tachycardia, or even a problem like advanced AV block or third-degree AV block due to some cause. Identifying whether a patient has a cardiac basis for symptoms is the focus of evaluation, because if a cardiac basis is not apparent upon close evaluation, the diagnosis by exclusion is that of neurally mediated syncope, which is basically a very benign entity with a good prognosis. And therefore, the focus should be on identifying if there is a cardiac basis for the patient's syncope. And depending on the outcome of this evaluation, we may need to undertake investigations such as Holter monitoring, or the use of an implantable loop recorder to document arrhythmias. And they are, as indicated. Now, with regard to distinguishing syncope from epileptic seizures, this is very important, because when you have a syncopal spell, you can have, as a result of the cerebral anoxia, transient myoclonic jerks. But this is not a primary epileptic seizure, but it's simply secondary to cerebral anoxia. And furthermore, the loss of consciousness is not going to last more than 30 seconds. And so these transient jerks are, again, not going to last more than a few seconds. The management for reflex anoxic seizures, which is a phenomenon I'm currently describing, is really not anti-epileptic medication, because this is not epilepsy. Therefore, it is important to distinguish syncopal spells from epileptic seizures, and sometimes the distinction is not apparent. But there is historical information that you can see that will allow you to make the distinction oftentimes. Now, historical factors suggestive of an epileptic seizure includes occurrence of the jerky movements even before the individual falls, tongue biting, cyanotic facial color, the presence of protracted confusion following that spell, which in the case of an epileptic seizure, we call post-ictal confusion. On the other hand, factors suggestive of neurally mediated syncope include the presence often of a pre-syncopal prodrome, about a minute or so, consisting of lightheadedness, nausea, sometimes sweating, um, feeling like you're going to pass out. And there is little or no confusion in the recovery phase of a syncopal spell, unlike in the case of an epileptic seizure. And then there is usually history of the presence of a provocative factor like prolonged, standing motionless. So these are, all this is to illustrate that, historical information is very important, and it's very important to distinguish syncope from epilepsy. Often, there are many reports of patients being misdiagnosed with epilepsy, given anti-epileptic medication, and they don't respond to it. Where in such instances, in retrospect, it's turned out that patients actually had just syncope and a reflex anoxic seizure. It was an epileptic in the first place. So the distinction is really critical. Now, the essential feature of neurogenic syncope, as I mentioned earlier, is you can see here there is abrupt vasodilation, and that the resistance is primarily in the arterioles. So abrupt withdrawal of sympathetic outflow to the arterioles as well as to the venules, so much so the blood will basically pool in the microcirculation in the veins. What has been found in some investigations is the disappearance of sympathetic activity to vascular beds, at the time of a syncopal spell, preceding the occurrence of hypotension. And so that speaks to the pathogenesis of hypotension. And it may be accompanied by an increase in vagal outflow to the heart, which causes bradycardia and or asystole. Triggers include strong emotions, seeing blood, which is what I call emotional faint, fear. It could occur in the setting of substantial blood loss, hemorrhage, more than 20% blood volume. Prolonged standing motionless is another provocative factor. Exposure to extreme heat, which tends to cause vasodilation by itself, is a provocative factor. Pain could be a trigger, and on occasions it could be the act of micturition and or defecation. So this figure shows time on the x-axis, and you have in the bottom panel integrated muscle sympathetic nerve activity, recorded with microelectrodes in the peroneal nerve, but the muscle sympathetic activity is just going to basically give you an index of sympathetic discharge to blood vessels and muscle, okay? You have systolic pressure, and then you have the RR interval. You can see that there is a reduction, basically disappearance of the sympathetic nerve activity. Compare it with what you see before. At the time the blood pressure falls, and you see, so there's hypotension, there is an increase in RR interval, which means the heart rate is decreasing, but at the same time you see the sympathetic discharge to blood vessels really dropping, showing the basis for the abrupt vasodilation in the case of neurally mediated syncope or vasovagal syncope. Now, in individuals who are suspected to have vasovagal syncope or neurally mediated syncope, studies have been done that show that these individuals with predisposition to a vasovagal reaction are unable to maintain adaptive responses to the upright posture for a long time. So for example, if you put the patient on a tilt table here, as you can see, the patient is trapped so that if the patient faints, she wouldn't fall to the floor. The ECG is recorded, the blood pressure is reported, the ECG is actually recorded continuously. And so whenever the patient has symptoms, she's asked to report, and the test is monitored. Blood pressure is taken periodically. And so you can document if the patient faints, whether that's accompanied by hypotension and or bradycardia. The logic is, as I mentioned, individuals predisposed to a vasovagal reaction are unable to maintain adaptive neural responses to prolonged orthostasis. That is what I mean by prolonged orthostasis is something like 20 minutes or 40 minutes of being strapped to the table upright passive. This is passive head upright tilt because the person is actually not standing actively and using the skeletal muscle pump in the leg. Rather, it's more passive. So it causes for venous pulling, and so that is then serving as a trigger, and it elicits the vasovagal reaction. It reproduces the symptomatology, and so it's something that can allow for us to establish a diagnosis of syncope, though this investigation is not something that is routinely needed in the evaluation of patients. But the reason I'm using it here is simply to illustrate that a fundamental abnormality in individuals with vasovagal syncope is that when it comes to maintaining the upright posture for a long time, there's a problem in maintaining that, and something kicks in and there is abrupt vasodilation with hypotension and a full-fledged faint. And that predisposition is there pretty much in all like healthy human beings, so much so the overall incidence of vasovagal reaction in a lifetime is literally like everyone gets it at one point or the other. So that's the rationale for the use of the head up tilt table test. It's basically a provocative test that unleashes the vasovagal reaction, and individuals who are susceptible to the reaction may show asystole and hypotension. Like this patient, you see there's a prolonged period of asystole. And then when that happens, you're going to bring the patient down, tilt the table back down to the horizontal position, and then things are back again to normal. You see, it's at point C, you see there is resumption of normal cardiac rhythm. Okay, so the question is, what is the cause of the abrupt vasodilation in the first place? Because that's what sets up the vasovagal cascade in motion, and that is unsettled. There are theories, but I will not dwell upon those theories now. At any rate, another interesting question, or important question rather, is when a person has hypotension, you expect a reflex increase in heart rate, tachycardia. That's how the baroreceptor mechanism works. But then why does this situation result in bradycardia, hypotension? How does it also lead to bradycardia and actually sometimes asystole? Because when it happens, it seems like the bradycardia is paradoxical. So let's look at the arterial baroreceptor response. You see that when the mean arterial pressure is below 60, the discharge in the afferents from the arterial baroreceptors, which is what we're seeing on the y-axis here, is pretty much zero. I mean, it's already minimal. And so we can say that when the mean arterial pressure is below 60 mm mercury, the arterial baroreflex is no longer the regulator of blood pressure because it's already maximally deactivated, and sympathetic outflow is already maximally increased as a result of it. Now, if you think about it, if you have, say, a scenario in which the individual is hemorrhaging and venous return is reduced and the heart's not filled properly, and the heart's actually being driven fast in the first place, which is what happens, tachycardia in response to hypotension. The vigorous contraction of a poorly filled ventricle is said to activate C fibers, afferent fibers in the heart, which, when going to the brainstem, leads to somehow activation of vagal outflow to the heart. So much so the result is then bradycardia and hypotension. This is called the Bezold-Jarisch reflex. The afferents are C fibers that perhaps sense the chemistry in the myocardium, and the reflex response is actually bradycardia and hypotension. So that's the Bezold-Jarisch reflex, and it can be triggered in the context of venous pooling or hemorrhage, and can therefore end up being the cause of bradycardia or asystole. If you think about it, you can ask if this might be cardioprotective. And if you think about it, if you have a reduction in ventricular filling, it's also a scenario where coronary blood flow is going to be reduced. And that scenario actually predisposes to myocardial ischemia because it increases myocardial oxygen demand. So slowing the heart in that scenario kind of reduces myocardial oxygen demand and may be cardioprotective, but that's speculation. Now, the other thing in terms of the mechanism that might underlie bradycardia and or asystole and vasovagal syncope is we have what are called the carotid sinuses and the aortic sinuses, but the aortic arch baroreceptors, but the carotid and aortic bodies. Now, the aortic bodies and the carotid bodies are chemoreceptors. They're sensing the chemistry, but they're also sensing the actual flow through them. And what you see is that when the arterial PO2 goes below 60, that's when they kick into action. But you see when an individual is acutely hypotensive with an MAP below 60, the blood flow through the carotid bodies and the aortic bodies decreases. Then the arterial chemoreflex is going to be activated. We discussed this earlier in another session about neural regulation of cardiovascular function. The consequence of arterial chemoreflex activation is vasoconstriction, an increase in sympathetic outflow to the blood vessels, but then a reflex lowering of heart rate, which, if you think about it, is going to lower myocardial oxygen demand or reduce it. So that's how the arterial chemoreflex works, and this or the Basile-Jurich reflex may underlie the bradycardia and or asystole in an individual with a vasovagal syncopal spell. Now, the hypotension due to the abrupt vasodilation and or relative bradycardia is going to lead to cerebral ischemia, but also ischemia of the vasomotor center. The individual faints and falls to the floor, so there's loss of consciousness. But this ischemia of the vasomotor center is a potent stimulus for an increase in sympathetic outflow to the heart and blood vessels. Okay, the individual is now recumbent as a result of the faint, but the recumbency is achieving or facilitating rather an increase in venous return. Now, the fact that the vasomotor center has been ischemic and it's gotten activated leads to an increase in sympathetic outflow. And this is the reason why the asystole and the bradycardia is self-limited. So the blood pressure, again, comes back toward normal, the heart starts beating, and systemic vascular resistance also moves back up toward normal, and everything is back toward normal. There is restoration of cerebral blood flow, and the whole spell is like no more than a minute. Sometimes individuals have prolonged asystole. I believe asystole as long as 84 seconds has been, documented. But recovery is the rule in the case of vasovagal syncope or neurally mediated syncope. Now, Angel has asked a question, well, which is better? And has proposed that under conditions of emotional arousal and psychophysiological uncertainty, like a fight or flight situation, there may be simultaneous activation of two emergency biologic regulatory systems. You have the fight or flight reaction, which we're familiar with, but there may be also activation sometimes of a conservation withdrawal system. That's the vasovagal reaction. It's like a conservation withdrawal system because it stops the heart, the individual faints, falls to the floor, only to regain consciousness. So on the other hand, with the flight or fright reaction, it can sometimes result in a lethal cardiac arrhythmia in an individual who is predisposed to it, say by virtue of a mutation like leading to long QT, for example. So the question is like, which is better? And the self-limiting faint or the vasovagal syncopal spell is something that's been evolutionarily conserved, and to an extent, all healthy individuals have that susceptibility. So the question is like, which is better? Obviously, the self-limiting emotional faint is better than dying of an arrhythmia when there's profound sympathetic nervous system activation. And the only difference is between syncope and sudden cardiac death, the two extremes, is that like you wake up after a syncopal spell. So that's Angel's take on it. That's the vasovagal syncopal spell and a lethal cardiac arrhythmia as two extremes in a spectrum of biologic responses activated in the context of emotional arousal and psychophysiological uncertainty. Now, there's this entity called carotid sinus hypersensitivity syndrome. Its prevalence is not known, but literally it means hypersensitivity of the carotid sinus or the entire baroreflex arc, the arterial baroreflex arc. The way carotid hypersensitivity or carotid sinus hypersensitivity is elicited clinically is through massage of the carotids or with firm pressure at the level of the carotids here, firm massage, and this is done with the patient actually in the supine position. Shouldn't be done with the patient sitting upright. If there is carotid sinus hypersensitivity, you see a ventricular pause for more than 3 seconds. You'll be recording ECG and or a drop in systolic pressure more than 50 millimeters mercury in response to unilateral carotid massage. Again, both carotids should not be massaged at the same time. So this is done, as I mentioned, with the patient in the supine position. The actual mechanism for the hypersensitivity of the reflex arc is obscure, but it could perhaps be in instances where there is a case report, which I said, and where the authors believed that carotid sinus hypersensitivity was a factor playing in the pathogenesis of syncope. This was the scenario. The patient was undergoing a thyroidectomy, and apparently for a thyroidectomy, the way the patient is positioned is like they hyperextend the neck. And so when you hyperextend the neck, perhaps you're like stretching the arterial baroreceptor, the carotids and the arterial baroreceptors somewhat. And an individual who has a hypersensitive baroreflex arc, that could precipitate a syncope and asystole, which was what happened in the patient during the thyroid surgery. But then it was apparently readily controlled. The patient was back to normal. So that is an instance of carotid sinus hypersensitivity. And this is believed to underlie syncope in about 30%, particularly the older patients with syncope, 60 years and older. Now, strategies for managing neurally mediated syncope and carotid sinus hypersensitivity is also a part of this umbrella entity called neurally mediated syncope. If the patient does not have structural disease of the heart, like aortic stenosis, hypertrophic cardiomyopathy, or a channelopathy like polymorphic VT or long QT syndrome, the prognosis is actually very good. It's a benign course, it's self-limiting, and no specific management is required other than reassure the patient, like advise the patient to avoid provocative factors. It's useful to and important to rationalize medications the patient is taking. For example, if a patient's taking a drug like an alpha blocker that's really not needed, you would take the patient off it because it would predispose to orthostatic hypotension. Drinking plenty of water, tensing muscles, leg crossing, being careful getting up after a period of recumbency, cognitive behavioral therapy, and in individuals who also have sick sinus syndrome as a predisposing factor. In those specific instances, an implantation of cardiac pacemaker may be indicated, not in other patients with vasovagal syncope, because the problem is really not the pacemaker. In the case of vasovagal syncope, it's really a reflex activation of vagal outflow to the heart. So, but if if an elderly patient who has sick sinus syndrome has recurrent syncope, the reason for implanting a pacemaker would be the sick sinus itself, rather than a vasovagal syncopal episode. So that's in summary about management of neurally mediated syncope. On the other hand, management of, if there is a cardiac cause for syncope, there is a specific management for each. In the case of aortic stenosis, it's probably surgical. But if it's a patient with long QT syndrome predisposed to polymorphic VT, it would be beta blockade, perhaps even placement of an implantable cardiac defibrillator. That's why it's very important in approaching a patient with unexplained syncope to rule out cardiac causes of syncope. And when you've ruled it out, then the diagnosis of exclusion is basically neurally mediated syncope or vasovagal syncope, and it carries a good prognosis. So, and here is a summary of the key points from this lecture. And neurally mediated syncope is actually, by and large, the most common cause of unexplained syncope across all ages. And as I mentioned just a while ago, evaluation of patients with recurrent syncope should focus on identifying whether there is a cardiac cause, structural or an inherited susceptibility of ventricular tachyarrhythmias, or even bradyarrhythmias, because that might increase the risk of sudden death. And the management of these conditions where there is a cardiac basis for syncope is really very distinct. It may be implantation of a pacemaker or an implantable cardioverter defibrillator, or surgery in the case of aortic stenosis. Whereas in the case of vasovagal syncope, the prognosis is good. So that's all I have.